everyone, and welcome back to Clinical Cousins YouTube channel. Today we're going to go over Wolff-Parkinson-White syndrome. This is also known as WPW syndrome. So this syndrome is characterized by an accessory bundle of fibers in the heart called the bundle of Kent. So this bundle of Kent can be located in various places, but the commonality is that it connects the atria to the ventricles in a way that the normal electrical pathway of the heart is altered. Remember that the James fibers are associated with LGL syndrome, while the bundle of Kent is associated with Wolff-Parkinson-White. So to remember all of the EKG manifestations associated with Wolff-Parkinson-White syndrome, all we have to remember is that normally short wide dudes sit pleasantly, or normal P waves, short PR interval, wide QRS complex due to delta waves, ST and T abnormalities with paroxysmal tachycardia, or a sudden, unpredictable bout of tachycardia. So, all of these will make sense here shortly, but we have to take a look at the electrical pathway in Wolff-Parkinson-White syndrome. So, we're going to make our own EKG tracing using lead 2. So, this is what lead 2 sees right here. So, first, we know that the SA node and atria depolarize. This creates a positive vector that is headed towards lead 2. This is normal. So far, so good. This positive vector toward a positive lead is what gives us our normal P wave. Now we have the problem. This electrical impulse will reach the AV node and the bundle of Kent at the same time. We know that the AV node will usually cause a delay in conduction. Meanwhile, the bundle of Kent doesn't offer any resistance. This is why we have a short PR interval. We see that this bundle of Kent will start to depolarize the ventricles here, right? This is why we have that short PR interval. Also, because the ventricles are becoming depolarized, it means that we will start to have a positive slurring, right? We are starting to depolarize positive towards a positive, so we have a positive slurring. This occurs for some time until the AV node finally conducts its impulse and it travels along the rapid conduction system in the ventricles. Therefore, we have a normal QRS complex. So, we call this positive slurring a delta wave. Remember, we'll have a wide QRS complex, right, due to this delta wave. This delta wave indicates the accessory pathway transmission of the impulse. Now, the reason that it doesn't look like a normal PVC is that the normal AV node will eventually catch up and it will create a normal second half of the QRS complex. To understand this, imagine for a second that the AV node doesn't work. If we let this bundle of Kent have all of the control, then our complex would look like a big, slow depolarization, followed by a negative repolarization. So this is sort of like how a PVC works. Basically, imagine that we have a P wave and we have a PVC. Now, the interesting thing with Wolff-Parkinson-White syndrome is that the AV node is working. So eventually, the impulse catches up and we have a normal second half of the conduction. So basically, this delta wave is the deformed monster baby of a PVC complex, the first half of a PVC complex, followed by the second half of a normal QRS complex. Okay, so what happens now? The ventricles repolarize. This creates a negative deflection, which can result in a normal ST segment and T wave, although these can be elevated or inverted due to the abnormal depolarization pattern that is given to us by the bundle of Kent. Remember that we depolarize this part of the ventricles abnormally, so it makes sense that we might have some abnormal repolarization, right? So the next thing that we need to know about Wolff-Parkinson-White syndrome is that it can travel orthodromically or antidromically. So ortho means correct, think like orthodoxy. Anti means the opposite or antichrist, right? Think the opposite of Christ. So we know that orthodromic conduction refers to the situation where the impulse travels down the AV node and then back up through the bundle of Kent, shown here. So ortho means correct, right? Because the impulse is being slowed by the AV node, it will create narrow complex tachycardias that are usually slower and more safe. On the other hand, we have the other situation, which is called antidromic conduction. This is where the impulse travels down the bundle of Kent first and then back up through the AV node. That doesn't sound right. Because the impulse does not have the benefit of the AV node delay, these types of tachycardias are usually odd-looking, wide complex tachycardias, right? They're wide complexes that are fast and dangerous. Also, in some cases, around 12%, the PR interval can actually be within range. Now, we know the WPW basics. We know the electrical pathway, we know the EKG manifestations, we know what orthodromic and antidromic conduction are. Now we need to know what the three types of WPW are. There's WPW A, B, and C. And to rapidly differentiate between the three types, we are going to cheat a little bit and we are only going to pay attention to leads V1 and V6. So we should memorize that if the delta waves, remember, if the delta waves in V1 are positive and the delta waves in V6 are positive, this will give us Wolff-Parkinson-White type A. If we have a negative delta wave in V1 and we have a positive delta wave in V6, this gives us Wolff-Parkinson-White B. Now, if we have a positive V1 and we have a positive V6, meaning the delta waves are positive in V1 and the delta waves are negative in V6, then we have Wolff-Parkinson-White type C. Type A is the most common, positive delta in V1, positive delta in V6. A is the most common, while C is the most rare. Another little fun clinical fact is that Wolff-Parkinson-White syndrome is often mistaken for an acute myocardial infarction on the EKG leads 2 and 3 and AVF, think the inferior leads, due to the fact that negative deflected delta waves, think about this turned upside down, can be mistaken for pathologic Q waves, which we will go over in a later video. This is called a pseudo-infarct pattern and can be easily misdiagnosed. So, what have we gone over today? We know that Wolff-Parkinson-White syndrome is associated with an accessory bundle called the bundle of Kent. This alters the normal electrical pathway and can have these following EKG manifestations. We can have a normal P wave, a shortened PR interval due to the excitation shown here. We can have a wide QRS complex due to the excitation shown here. We can have delta waves due to the excitation shown here. And we can have ST&T abnormalities because we depolarize this area of the ventricles in an abnormal way. So it makes sense that when we repolarize, right, our ST segment and our T wave, we can have abnormalities. And lastly, we know that the two different types of tachycardias that are associated with Wolff-Parkinson-White, we know are orthodromic and antidromic conduction. Orthodromic means the right way, antidromic means the opposite way or the wrong way. So when we have orthodromic conduction, we know that it is going through the AV node and back up through the bundle of Kent. We know that these are slower, narrow complex tachycardias that are a little bit more safe. Now, with antidromic, we know that it is going through the bundle of Kent first and back up through the AV node. Remember, nothing should come back up through the AV node. These generate wide complex tachycardias that are more dangerous because they don't have that AV nodal conduction delay. And lastly, we know that the different types of Wolff-Parkinson-White syndrome can be determined by looking at the positive or negative delta waves in leads V1 and V6, with A being the most common and C being the most rare. As always, thank you for taking the time to learn with us today, and remember to like and subscribe for more content.